I will be talking to you in the next 8 minutes about whether anti VEGFs are better to treat a diabetic retinopathy or we have to do a laser. Now, I don't have any financial disclosure, and let's look at what anti VEGFs actually do. Anti VEGFs basically decrease the vascular permeability. They stabilize the blood retinal barrier. They decrease the macular edema in turn. And the another activity of an anti-VEGF agent in a proliferative vitreoretinopathy is basically it causes a decrease of the activity of the fibrovascular proliferation. Now, when we look into the histology of once you give an anti-VEGF injection into the eye, and when we look into the histology, what anti-VEGFs actually do is they cause apoptosis of the vascular endothelial cells, and they cause overexpression of the smooth muscle of the capillaries. And in addition to that, they increase the pericyte coverage around the capillaries, and thereby reducing the vessel penetration and hence making the capillaries less leaky. Remember, anti-VEGF agents have got a shorter time of action inside the eye. So there is a temporary reduction of blood flow in the newly formed blood vessels, but they do not induce a complete regression of vascular endotheliums. The blood flow of these newly formed blood vessels may be easily reperfused when the effect of the anti-VEGF goes off in the eye. Now, what does this anti-VEGFs, why these anti-VEGFs actually stimulate fibrosis? In fact, I think Dr. Amit has shown one beautiful photograph where prior to the PRP, the macula was fine. After the PRP, he found that there is a sheet of fibrous tissue which was formed on the surface of the macula. Now, what exactly happens is what I am going to tell you now. What happens following an anti-VEGF injection is there is an increase of fibrous component. The traction increase. A TRD can become much worse, or a TRD can progress itself into a combined RD. Now, what exactly happens in the eye is there is a shift in the balance between the connective tissue growth factor and the VEGF, and which is why there is a switch from angiogenesis to fibrosis, which in turn is the reason why the patient develops more of fibrosis when an anti-VEGF is injected, or for that sake even when laser is done to the patient. Now, let us see what a laser does to the eye. Laser basically, when you talk about the panretinal photocoagulation, it converts the hypoxic areas into anoxic areas, and it permanently reduces VEGF production in that particular area where the PRP mark is done. When you do a focal laser, all you do is you close your microaneurysms. That's what we achieve by doing a focal laser. What do we do? What do we achieve when we do a grid laser? Honestly, none of us really know how a grid laser works, but we all know that it works to a certain extent. And the probable theories which have been said is it stimulates the RP pump, or there is a decreased need for oxygen in the macula, and there is a reflex vasoconstriction of the macular blood vessels, capillaries, and as a result of which the edema tends to subside. Now, in the pre-anti-VEGF era, that is 5-6 years back, the only treatment options which we had for a diabetic retinopathy were either we do a laser treatment, keep doing laser. If laser doesn't work, or if there is some other indication for surgery, then we go ahead and do the surgery. Now, the treatment protocol has changed a little bit following an anti-VEGF era. That is, you inject an anti-VEGF agent and you follow it with a laser, or you inject an anti-VEGF agent and you can follow it by surgery. And the anti-VEGF injection, Now, I just want to show you a picture. Now, you have an edema like this with there is a diffuse component, there is a gross cystoid chain, there is a sensory detachment in both the eyes of these patients. When the macula is thickened beyond 400 to 500 microns, if you want to go ahead and do your macular laser or a grid or a focal or whatever it is extremely difficult to get you need to keep on increasing your power, and in fact you are going to cause more damage onto the macular area. So now what has anti-VEGFs done to us? These anti-VEGF agents have basically reduced the macular edema and made macula little more amenable for treatment for laser photocoagulation. That is exactly what the theory is when you use an anti-VEGF in treatment of diabetic retinopathy. In a proliferative diabetic retinopathy like this, you can see there is a large NVD, there are multiple NVEs, and their mid-periphery there were large multiple NVEs. In such a situation, if you directly start doing a photocoagulation in such a situation, there could be a process of a subhyaloid heme, or you can throw up a bit heme in these patients. So you have another option of treating this particular patient is the similar patient who had underwent an anti-VEGF exactly a week after that the photograph looked like this, and subsequent to that you can start off your panretinal photocoagulation, which is of more permanent effect. Now let's look at some clinical evidence suggesting that whether anti-VEGFs are really useful, or are they better than laser, or do they complement each other. I think what Dr. Ajay was talking about is the DRCR network. This is one of the trials which has really put into. There are a lot of other studies also, but this is one of the trials which has actually gave us a good idea what happens when you treat patients with different modalities. Now, I just will briefly tell you the result. What they said in one of the trials is, in a patient with anti-VEGF in a prompt laser group, at the end of 1 year, they had almost 9 letters of improvement. Whereas with an simple anti-VEGF agent without a laser, also still the patient had got a good visual acuity following at the end of 1 year. And in a patient who had undergone injection of triamcinolone with the laser, the number of letters of improvement was much lesser when compared to the anti-VEGF group. And when you do the sham and only the prompt laser group, the number of letters of improvement was only almost comparable to the triamcinolone group. Now, what else did it tell you is, there is a reduction in the mean central subfield thickness in the triamcinolone and the prompt laser group. It was almost similar. Whenever you, in the triamcinolone group and in the anti-VEGF group, the central macular thickness was supposed to be the same. The amount of reduction of the central macular thickness was almost the same. But whereas in the only laser treated group, the amount of decrease in thickness in the central macular area was much lesser. And in pseudophakic eyes, the difference was not much between the triamcinolone group and the anti-VEGF group. And the 2-year visual outcomes were almost similar to the 1-year visual outcome. So the evidence which the message which this particular study has shown us is, basically it is trying to tell you that if you use a combination of anti-VEGF agents along with the laser, there is a better chance of visual acuity improvement as well as better chance of maintaining the macular thickness at the optimum level. There's another study which is conducted to compare only anti-VEGF agent along with the management with along with the laser therapy. Now, in the patient who had taken only anti-VEGF agent, they had definitely a better visual acuity outcome. The macular thickness was much less. But look at this: you need almost 9 injections in a year to get to achieve that particular level. Laser also has some improvement in visual acuity, not matching with the anti-VEGF group. The macular thickness was not comparable to what we see with an anti-VEGF group, but it also required an average of, Amit was telling us about, it requires almost 2.5 sittings of focal laser to get the macula, to really have a good effect on the macula. And you see, it almost needed 3 sittings of laser to the macula to get to a reasonably reduced macular thickness. Now, what are the lessons which we learned? So, in a patient with thickened macula, laser is really not very effective. So, what anti-VEGFs do is they decrease the thickness, and hence laser becomes more effective. Remember, any angry looking polyp which you see, it can regress following your anti-VEGF, and subsequently you can do a panretinal photocoagulation, which helps in maintenance of this regression or probably decrease the FVP. So now, which is better? I would say the combination of anti-VEGF and laser is definitely better, because they both of them complement each other. To conclude, laser still remains the gold standard of treatment. The reason why laser still remains the gold standard of treatment is because laser has got a long-term effect, whereas anti-VEGFs do act as an adjuvant, because basically anti-VEGFs have got a short-term effects, and I would say they are complementary to each other. Thank you for your patient hearing.